Great. Well, thank you so much. It's truly an honor to join you all here tonight. My name is BRIAN WATERMAN. I'm here at Wake Forest University in Winston-Salem, North Carolina. It's an honor to present to my colleagues through AMECRA as well as all throughout Latin America. It's really an incredible collaboration, and one I hope to continue beyond the virtual stage as we transition back towards meetings. My charge is really to look at biologics and meniscal repair and what I think are the next generation of techniques that bridge us to future innovations. My disclosures can be found online through the AAOS program, none of which are really relevant to the content of this talk, as you can see through this slide. What I'd recommend is that you buckle up. There's a lot to take in this presentation. We'll try to highlight several of the key features. But one of the most key features is that our charge is meniscus preservation. When you think about the knee as the organ, really the meniscus comprises a small but very vital component of it, alongside cartilage health, malalignment, and stability with ligamentous competency. The functional implications of the meniscus cannot be understated. While acting as a shock absorber, it's also important for force dissipation and dynamic stability. And so we really need to focus on that meniscal status because it's very intimately linked in with cartilage changes. We know that the meniscus and the cartilage can be the most important factors in predicting outcomes after ACL reconstruction. So as goes the meniscus, so goes the future of the knee, both in terms of form and function. What we know is that also these small tears, while seemingly meaningless at the time of initial surgery, with resection and removal of even a modest amount, anywhere between 30 and 20%, can reflect significant areas of damage in the future. As you can see, a widespread collapse, particularly this lateral joint line, in somebody with significant valgus deformity that advances to level of arthritis in a young female. So what do you do in an individual where you encounter this meniscal tear with seemingly poor quality tissue, potentially some cartilage defects in an otherwise active patient population like I've taken care of here in El Paso in North America? Well, most of our colleagues traditionally manage this with meniscal debridement. You can see the rates of this in this study from 2013 show that meniscus debridement alone really outpaces that of meniscal repair. And even when we utilize meniscus repair options, whether it's outside in, inside out, all inside, our pooled failure rates may be still 1 in 4. And so why does that happen? Why do we continue to experience these failures at such high rate? Well, we know a lot of the underpinnings of this are as a result of the vascular nature of the meniscus. Only the peripheral third is perfused, whereas the remainder undergoes nutrition through diffusion or mechanical pumping. Also, not all meniscal patients are the same. There are a variety of different lesion-specific factors that play in, concomitant injuries, as well as patient or host factors. And so what we want to do is increasingly stack the deck for those modifiable factors that we can really affect change on. And those include the biology of the meniscus. I'll focus on these biologic adjuncts, some of which are tried and true, and some of which have continued to evolve as we push forward. From mechanical stimulation with rasping, trephinations, synovial abrasion, marrow venting, as is shown in the bottom right, fibrin clot use, platelet-rich plasma, as well as potential role evolving for bone marrow aspirate. Trephination starts with creation of these full-thickness vascular access channels to the periphery of the meniscus, and the goal is to try to create these perfusion of the blood products from the more vascular peripheral third. You can also obtain this through shaving the torn areas of the meniscus or capsule to promote bleeding to this area. Fibrin clot is a time-honored agent for this, and we've used this as a chemotactic stimulus for reparative cells, as well as a potential to provide scaffolding for this reparative process. With benefit in the historical literature, you can create this fibrin clot gummy that's applied to our inside out or all inside sutures, and then that's placed at the site of repair to again organize healing. Marrow stimulation or marrow venting is typically performed on the anterior notch, and it can be performed just in front of the ACL footprint in order to introduce marrow elements in the knee that hopefully recruit improved healing of meniscus repair. PRP is obviously taking on our world by storm. It was first utilized in 1990 with multiple different growth factors that are beneficial for neovascularization and acceleration of healing. But there are a wide variety of commercially available systems, and these can have important repercussions for the level of not only platelets and leukocytes, but different growth factors that we're trying to harness. So it's important to be aware of the limitations of your unique system. As well, it's also important to realize there are differences both within and between our patients based on a variety of different lab draws and proprietary processing methods. So take these into account as you consider this homeostasis. What we're trying to do is improve access to reparative cells, outpace degradation with synthesis, and increase the availability of bioactive factors. Bone marrow aspirate may also additionally have a role, and while it's a rich source of progenitors that can differentiate into end-level mesenchymal connective tissue, really our clinical efficacy and cost effectiveness in humans has really not matched up quite yet with that of the in vitro and animal model research. If it is to be utilized, where should it be obtained? It can be obtained from the iliac crest, proximal tibia, and proximal humerus. My preferred technique is to utilize the iliac crest. It is a limited area for donor site morbidity. You're typically able to obtain adequate volumes in order to get a 3 to 4 cc's for reintroduction. And again, this is a rich source of mesenchymal cells. Patients tolerate it quite well, and it usually can be done on the ipsilateral side with relative ease at the beginning of the case. Well, how about the data? This is the most sticky part of this discussion. What's important to realize is that bone marrow venting continues to be something that contributes positive results in the literature. You can see of this study, 37 patients with isolated meniscus repair and bone marrow venting had rates of failure that are fairly comparable with that of ACL patients with meniscus repair. And when you compare that to that historical subset of isolated meniscus repairs, definitely nearly less than half of the rates of failure. And there were no significant differences between the cohort. And so there may be a biologic milieu like that of the ACL meniscus repair. Well, what about comparing this to controls? Again, 23 bone marrow venting versus 21 patients in control. An excellent study was looking at second look arthroscopy at week 36, 100% healing in the marrow venting versus 76% in control. And the bone marrow venting had improved patient-reported outcome scores. What about the systematic reviews on this? Well, failure rates are lower, again, in the pooled data, 17% versus 22%. However, in this study, they showed no significant differences in patient-reported outcomes with the exception of one study. Separate study looked at rates of PRP augment CL, and they showed an odds ratio that decreased the rate of failure among patients with PRP administration. This is another elegant study from David Flanagan and colleagues at Ohio State. Again, they showed an isolated meniscus repair measurably increased improvements in failure rate when compared with no PRP in the isolated meniscus repair group. So important to key that in. We're designing a study, and this is with Dr. Aravind Athaviraham in University of Chicago, and we're looking to compare this marrow venting versus PRP to try to establish which is superior of patients with isolated vertical, oblique, and radial tears with repair techniques dictated by a tear pattern and surgeon preference. So what are my indications? Really isolated meniscal pathology in hosts that potentially need additional biology. And these can take a lot of different forms: radial tears, horizontal tears that we're performing a repair, these complex variants where you can see it's probably unclassifiable there centrally, and as well these short oblique or parabeak tears that we've traditionally written off, as well as the discoid tears that require treatment. This is all alongside the standard vertical pattern. Well, these are two cases that I would have classically cast aside as not repair candidates. In this one, you can see rasping of this horizontal component, and then there's a bucket handle variant. So we're using the rasp, we're performing shaving to remove any residual scar tissue at the interface and to stimulate healing. And then you can see us perform marrow venting of the notch in order to recruit lower local marrow cells. Well, in this case, we were able to perform a repair using a combination of all-inside devices and outside-in techniques. You can see at the conclusion there on the right, and she has just returned back to running activity at 12 weeks for an injury that was probably present for upwards of 2 years. Case number 2, another one utilizing all-inside devices. You can see this ramp to horizontal component in a fairly complex case. You can see we performed a repair, we've reapproximated it nicely, and then augment bottom right with PRP in order to try to augment healing. Again, a patient that's returned to lacrosse, high school athlete, chronic tear at about 12 to 16 weeks. So again, really meniscus preservation is key. And as we consider the knee as an organ, we really need to consider those biologic adjuncts to try to address this meniscal sufficiency arm of our cartilage health. This is not only good for weekend warriors like the guys in the top right, but really the elite level athletes, as you all well know, in the bottom right. So thank you so much, and I look forward to your questions. I'd also like to thank our team and colleagues from Mexico that have continued to contribute back to my understanding, including Fernando shown in the bottom right. So thank you for having me, and feel free to contact me with any additional questions you might have.